Hello everyone. In today's lecture, we'll be discussing about hypotonicity in neurological patients, also known as floppy muscle tone presentation. So this is really important topic because it directly impacts motor development, function, and rehabilitation strategies. So coming to the introduction, hypotonicity refers to the decreased resistance to passive movement, and it often presents with what we call a ragdoll posture. So patients may show a joint hypermobility and reduced deep turn on reflexes. It is most important to note that hypotonicity is not the same as weakness, though the two may coexist as well. So for example, research suggests that 50% of children with cerebral palsy present with hypotonia. Yeah, this is what I've told before, that is the ragdoll posture, joint hypermobility, reduced DTR and steps and all. So coming to the neurological basis, so what causes hypertonicity? So there are several neurological mechanisms involved. The first one is cerebellar dysfunction. That is, this reduces gamma loop activity and affects coordination. The second one is the lower motor neuron lesion. Conditions like spinal muscular atrophy or Guillain-Barré syndrome, that is commonly called as GBS, reduce alpha motor neuron firing. Sensory processing disorders like when proprioceptive input is inadequate, muscle tone regulation suffers. So some common clinical conditions associated with hypertonicity include Down syndrome, stroke, traumatic brain injury, cerebral palsies and stuffs. Coming to the clinical assessment of hypotonicity. So when assessing hypotonicity, clinicians typically use a combination of observations, palpations, and standardized tools. So on observations, patients show postural instability, a wide base of support, and reduced spontaneous movement. On palpation, the muscles often feel soft and doughy at rest. With passive movement, there is usually an increased range of motion and less resistance is felt. Whereas in standardized assessment tools like TIMP, that is test of infant motor performance, and gross motor function measurements helps in objective measurements as well. Coming to the core treatment goals, the key rehabilitation goals when treating hypotonicity are, for the first one is improving stability, especially posture stability and balance reactions. The second one is enhancing strength, particularly in anti-gravity muscles, since it helps in mobility and ambulation stuffs. So promoting motor movement control so that the functional motor patterns develop, preventing complications such as joint subluxations and contractures will be helpful. And maximizing participation is nothing but enabling the patients to engage more in daily activities and development kind of stuffs. Coming to the general rehabilitation and principles, there are few guiding principles in hypotonicity management. Early interventions is crucial, especially in children, to harness neuroplasticity. Proprioceptive input through deep pressure, joint compression, and weight bearing helps to regulate the tone of the muscle. Core stability training provides a foundation for posture control and limb movement. And finally, task specific training, meaning repetitive practice of functional activities, is essential as well. Coming to the specific interventions, treatment strategies can be divided into therapeutic exercise and modality assistive devices. First, looking upon the therapeutic exercise includes strengthening exercise for trunk extensors and hip abductors, and PNF techniques such as rhythmic stabilization is also given, whereas balance training on unstable surfaces is also encouraged to patients, and weight bearing activities like quadruped, kneeling, and standing frame exercise is also given. And coming to the modality and assistive devices, aquatic therapy where buoyancy assists movement and hydrostatic pressure offers resistance, neuromuscular electrical stimulation, that is NMES, and orthotics like AFOs is also given, and adaptive equipment such as standers, gait trainers, and specialized seating systems is also being given to such patients. Interdisciplinary approach and prognosis is most important. Managing hypertonicity is rarely a one-person job. A collaborative team involving physiotherapists, occupational therapists, speech therapists, physiatrists, neurologists, and orthopedists provides best outcomes. So prognosis largely depends on the underlying conditions, but the overall aim is to maximize the functional potential. So equally important is caregiver education. Families need to understand the program, that is home program, and providing ongoing support is most important. And coming to the conclusion, to wrap up, hypertonicity management requires comprehensive and individualized care. With the right strategies, we can help the patients improve motor control. Thank you for watching.